Good morning, everyone, and welcome to our webinar today. This is the Adverse Childhood Experiences, Implications for Nicotine Addiction and Tobacco Treatment webinar produced by the Behavioral Health and Wellness Program through our partnership with the Vermont Department of Public Health. Our speakers today are Christine Garver-Apgar and Susan Young. And with that, I will let them take it away.
Thanks, Sean. So thanks everyone for joining us for today's webinar. So for those of you who may have missed last month's webinar, I'll just repeat our introductions briefly. I'm Christine Garver-Apgar, and I'm a research associate at the Behavioral Health and Wellness Program. And once again, I'm joined today by my colleague, Susan Young, BHWP's research director. This is actually the second presentation in a two-part series. So last month, Susan and I focused on pathways by which adversity and trauma experienced during early childhood can have lifelong impacts on health and wellness, both for the children who experienced the adversity themselves, but also for future generations. And we also touched on findings showing that early adversity predisposes individuals for poor health behaviors, including addiction. But today we're going to focus more specifically on how addiction during and how early adversity influences that addiction. So I'm going to spend the first part of today's webinar discussing pathways by which early childhood adversity can lead to greater risks for addiction. And I'll talk specifically about how early adversity impacts tobacco use and cessation attempts. And then finally, I'll explore how those associations differ between men and women and how this knowledge can inform and potentially improve our tobacco treatment efforts and clinical practices. And then I'm going to turn the presentation over to Susan, who will discuss trauma-informed care, which is a clinical approach that grew out of addiction treatment more broadly. So just to review what I mean when I'm referring to early childhood adversity, we're typically talking about child abuse or neglect. It could be psychological abuse or physical abuse or sexual abuse. It could be violence experienced in the home, such as domestic violence, or it could be parental behaviors or characteristics, things like substance abuse in the home, or mental illness by a parent perhaps, or criminal activity by somebody in the home. This is how the original Adverse Childhood Experiences study characterized early adversity, but each study defines this early adversity idea slightly differently. And many of the studies that I'll be talking about today focused more specifically on forms of child abuse or child neglect, so the more severe types of early adversity. So, as we discussed last month, chronic stress experienced during early childhood has been shown to increase the likelihood that individuals will develop addictions in adolescence and adulthood, including nicotine addiction. So, for example, studies looking at effects of childhood sexual abuse find roughly a 6-fold increase in the risk of substance abuse or dependence for people who experience this type of abuse as children. But how is it that we go from experiencing early adversity to addiction specifically? What are the pathways that lead from one to the other? So in the next few slides, I'll talk just a little bit about current scientific thinking around how this happens. The association between early maltreatment and either alcohol or drug use manifests at a very, very young age. So a large school survey, for example, in 1999, collected data from students in 8th, 10th, and 12th grades. And the students were asked about past and current substance use and also whether they had ever experienced physical or sexual abuse. And the study found that having experienced abuse in the past was associated with more than a threefold increase in the odds that alcohol or cigarette experimentation had occurred by age 10. So this is very, very young initiation of substances. And it found more than a 12-fold increase in the odds that marijuana use or regular drinking had occurred by age 10. Studies like this are important, and they suggest that exposure to early stress shifts the initiation of drug use to younger ages. And we know that almost 90% of American adults who are daily smokers started smoking as adolescents. So this is an important point, because as a result, a substantial percentage of abuse victims become exposed to substances during a vulnerable developmental window when substance use is much more likely to lead to future abuse and dependence. We talked a little bit last time about the HPA axis, which is a component of our stress response system. The HPA response, just to review, results in cortisol being released, often in response to psychosocial challenges, such as those presented by the types of childhood adversity that we're talking about today. And we talked about how early childhood adversity can lead to sustained chronic HPA activation, which has neurobiological consequences for how the brain develops during childhood. In particular, chronic stress can alter how reactive a person is to environmental stressors, although the direction of the effect actually varies across studies. So a few studies show increased cortisol activity in response to stressors when a person has experienced chronic early adversity. But actually most studies show diminished reactivity or a blunted cortisol response to environmental stressors after a person experiences chronic stress during early development. So I want to talk a little bit more about this effect of blunted stress reactivity, because it turns out that blunted cortisol responses are associated with a number of personal characteristics that are also risk factors for substance use disorder. These things include poor mood regulation, which we talked a little bit about last time, impulsive behavioral tendencies, and risk-taking. Decreased cortisol release may alter reward pathways so that individuals experience reduced dopaminergic activity and reduced experience of reward, and potentially greater chronic dysphoria. So in this way, substances which stimulate dopaminergic activity can kind of be seen as self-medicating behaviors. And I should note here that smoking, in turn, can actually result in further blunting of the reward sensitivity pathway through inflammatory processes. So the relationship here between smoking and blunted dopamine activity actually goes both ways. Reduced stress reactivity is also likely to diminish internal cues that are associated with danger when an individual is confronting risky choices. And we talked last time about cognitive impairments and reduced executive function abilities, and so a reduced willingness to delay gratification, which relates to executive function capabilities, that may also contribute to risk-taking in daily life. And finally, unstable affect regulation and a tendency toward negative affect may also contribute to a behavioral style that seeks to alleviate negative mood states. So when you take all these things together, these may all plausibly contribute to an impulsive behavioral style and a greater willingness to take risks, and with a reduced aversion to the potential negative consequences of those risks. So over a period of years, these behavioral tendencies can contribute to risk for addiction and poor health behaviors more generally. I'm going to talk for just a minute about a hormone called oxytocin. You may be familiar with this hormone in contexts related to lactation and giving birth, and it is important for those activities. And you may also be familiar with this hormone's role in social attachment and bonding. Oxytocin has been thought of as a sort of a pro-social hormone, which can serve to increase resilience and therefore reduce the likelihood of developing addiction. And in fact, administering oxytocin as a potential treatment for drug addiction has actually been suggested in the literature. But I wanted to bring this up because there's kind of a newer thoughts and somewhat unexpected findings recently that have demonstrated actually higher levels of oxytocin in people affected by heroin use disorders compared to people not affected. And there is a literature on, in some contexts, oxytocin leading to increased aggression and other what you would think of as more antisocial kinds of behaviors. And so these newer and unexpected findings have led to a new hypothesis suggesting that rather than just being a pro-social hormone, oxytocin increases the importance or the salience of social cues, whether those cues are positive or negative. And so in positive environments, oxytocin may promote pro-social behaviors and increased resilience as a result, whereas in unsafe or adverse environments, oxytocin may actually act more counterproductively to promote more defensive and antisocial emotions and behaviors. And if you're wondering what this has to do with substance abuse, the latter adverse environments are what typically characterizes the clinical history of patients managing addictions. And so this pharmacological approach is probably a bit premature if what oxytocin is doing is increasing the salience of whatever environment a person is in. And it turns out, too, that there is a lot of heritable genetic variability across people in oxytocin concentrations. And it's thought that these differences in combination with early experiences may actually contribute to diversity and the vulnerability to mental health and addiction. So in this view, high oxytocin levels may actually be a risk factor for mental health problems and substance use in individuals who experienced early childhood adversity in particular. And I just wanted to mention that because oxytocin has been discussed as a potential pharmacological approach. And it could still be, but I think a lot more research needs to be done on oxytocin's impacts. So let's now turn our attention to how early adversity during childhood impacts tobacco use specifically. There are a few studies looking at this, although these associations are actually less well established than associations with addictions more broadly. The first study that I'll mention was based on the same original ACE data that I talked about last time. This is the Adverse Childhood Experiences study. But I'll just give a few additional details of that study that are related to tobacco use. So compared to people reporting no adverse childhood experiences, people who report more than 4 different categories of adversity exposure had substantially higher risks of early smoking initiation. So they were, and by that we mean regular smoking that happened by 14 years of age. So they were over 5 times more likely to start early smoking initiation. They were 3.1 times more likely to report ever having smoked, and by that we mean having smoked at least 100 cigarettes in a person's lifetime. Is likely to report current smoking, and they were almost 3 times as likely to report heavy smoking, and by that we mean at least 20 cigarettes a day. A couple of other studies have looked only at women, and they find that Similarly, women who had experienced both childhood physical abuse and sexual abuse were anywhere from 2 to 3.5 times as likely to start smoking by age 14 as those who did not experience that kind of abuse. So the studies that we just talked about looked at tobacco use, but they didn't necessarily examine nicotine dependence. So a couple of studies have examined effects of childhood adversity on a DSM diagnosis of nicotine dependence, or a Fagerstrom test for nicotine dependence. And these studies have found that experiencing early adversity does increase the risk for diagnoses of nicotine dependence. Another study looked at diagnoses of nicotine dependence and also whether types of childhood adversity predicted the persistence of that dependence over a period of 3 years. And in that study, nicotine persistence was predicted by all types of abuse and physical neglect that were examined. And also demonstrated that both depression and childhood adversity independently predict smoking persistence in patients experiencing serious smoking-related illnesses. These studies are important because they suggest that not only does childhood maltreatment affect risk for nicotine use and dependence, but it also appears to affect the course of the disorder, which is consistent with the idea that childhood maltreatment is associated with more severe substance use problems, probably stemming at least in part from the fact that childhood adversity predicts earlier initiation of substances like we talked about, including nicotine. So I want to talk now a little bit about treatment outcomes. Both trauma exposure and the experience of adverse childhood experiences are strong predictors of depression. And this is important because research has consistently linked negative emotions and depression to other important smoking variables that tend to complicate an individual's attempts to quit. So for example, research shows that negative emotions related to stress decrease a person's ability to resist smoking. And actually, these negative emotional states are associated with an increase in the number and velocity of puffs that a person takes while smoking a cigarette. And we know that can influence nicotine dependence. For the chronic smoker who attempts to quit, depression, anxiety, craving, and anger have been linked to relapse following a quit attempt. Individuals with a history of childhood maltreatment, in addition to these variables, may also be less resilient in overcoming substance dependence due to a few things: reduced sense of autonomy, which could affect their confidence in taking steps needed to recover. They tend to rely on avoidance-based coping strategies, and they tend to have strained interpersonal relationships, which results in reduced social support. Individuals with and without childhood maltreatment may also differ in treatment seeking, and that could affect nicotine persistence. So given these relationships, it's really important to consider how life adversity and trauma influence nicotine dependence and relapse. Studies in this area are fairly limited, but one recent study looked at the extent to which childhood adversity was associated with smoking cessation outcomes that were prospectively assessed. And it found that people who relapse within the first 4 weeks of quitting have experienced more adversity than people who are able to maintain their abstinence. There was also a suggestion in the data that if you just look at people who didn't have any childhood adverse experiences, former smokers who avoided relapse tended to experience diminished cravings for nicotine over time. Whereas if you look at the groups of people who reported having experienced early childhood adversity, cravings for nicotine actually increased over time for those folks. And finally, within individuals who relapsed, the data show that women reported higher levels of adversity than men. And this last finding, demonstrating a gender difference, is actually really common in this literature. So I wanted to spend just a few minutes talking about gender differences and how early childhood adversity impacts tobacco use and cessation. So, for example, women are more likely to be diagnosed with depression. They're more likely to benefit from social support, and they're more likely to have concerns about weight gain when trying to quit smoking. So an understanding of how gender differences and psychosocial factors affect smoking behavior may be important in developing personalized smoking cessation strategies. And as well, we know from research that looks at sex differences, not taking childhood adversities into account necessarily, but just general sex differences. We know that women have a harder time quitting, and we know that certain biological treatments like nicotine replacement therapy tend to be less effective for women. I'm going to talk now briefly just about a couple of studies related to childhood adversity, though, which exemplify the idea of how new information about gender differences could potentially inform treatment strategies or have other clinical implications. So in one really recent study, researchers investigated whether attachment insecurity, which we know is associated with childhood adversity, might be a pathway by which early stress leads to smoking. So attachment insecurity refers to two things: attachment anxiety, which is a fear of being abandoned, and attachment avoidance, which is sort of a devaluation of intimate relationships and tending to prefer emotional distance. Attachment insecurity is known to be associated with harmful health behaviors, including smoking. And so what a recent study found was that in women, but not in men, attachment anxiety was associated with current smoking. And as well, attachment anxiety seemed to partially account for the association that we see between adverse childhood experiences and smoking. So how could these results potentially inform treatment practices? People with high attachment anxiety often exaggerate expressions of helplessness, and they will often focus coping on managing negative emotions rather than on problem-solving strategies. And we also know that women in particular are more likely than men to adopt emotion-focused coping. So a tailored treatment strategy for women who have experienced early childhood adversity and who demonstrate subsequent attachment anxiety and who are trying to quit might be to supplement standard care with increased social support. Another study examined the degree to which serious psychological distress may account for the relationship between early childhood adversity and smoking cessation in terms of the motives, attempts, and successes to quit smoking. In men, it turns out that neither childhood maltreatment nor serious psychological distress was associated with smoking outcomes. But in women, early adversity and serious psychological distress were associated both with a lower likelihood of quitting and also with making a successful quit attempt. So similar to the previous study we talked about, serious psychological distress also seems to account for some of the relationship between early adversity and poor cessation outcomes. Interestingly, in the study, women who had been maltreated as children actually had stronger concerns about smoking, and they had a stronger motivation to quit than those who hadn't experienced early maltreatment, despite having less successful quit attempts. And so the implications are that women who smoke and who have a history of childhood maltreatment are motivated to quit smoking, but they have more difficulty quitting as a result of the serious psychological distress that they're experiencing. And so gender-sensitive treatment for women who experienced early adversity might capitalize on a greater than average motivation to quit smoking, and it could focus more on translating that motivation to successful action. So with that, I am actually going to turn this presentation now over to Susan Young, who will talk about trauma-informed care.
Thanks, Christine. So yeah, we're going to switch gears a bit and now talk about how understanding these mechanisms and these research findings that we've just reviewed can inform clinical work and organizational design for delivering the best care for tobacco cessation as well as addiction treatment more broadly for folks that do have a background in adverse childhood experiences or other kinds of trauma. The topics I'm going to try to cover are the importance of early screening and assessment for adversity and trauma and the importance of that as a first step. And then I'm going to review the development of a treatment model called trauma-informed care, which many of you are probably familiar with. I'm going to give you a little bit of history about how the model was developed, as well as some of the guidelines for building these models in your own organization. And then I'll end with a few bits of information on the many, many resources that are available for organizations that are interested in building in a trauma-informed model in their healthcare organization in terms of guidelines, training, technical assistance, and so forth. So that's what I'm going to try to cover today. So as I mentioned, early screening and assessment are the focus or the first step really in trauma-informed care. And early is the key word here. It's, as it is in many clinical contexts, it's critical to conduct screening and assessment as soon as possible after any significant adversity or traumatic event is identified or even suspected. And there are some key steps that have been put forward in terms of screening. The first is just the recognition that an event has occurred that's potentially traumatic. And the reason it's noted as potential is because what one person may see as a traumatic event, another person may not interpret the same way or not feel the same impact of. So then the second step, of course, is to evaluate the effects of the event. So again, individual differences in how the event is interpreted, the severity as well as sort of the nature of the trauma related to this event. And these, of course, can be single events or more chronic adversity events that we've discussed already. The next level is really an examination of the capacity for coping with these effects. So evaluating an individual patient or a family level assessment of sort of what are the coping abilities and strengths in the context of perhaps addictions or mental health issues or the family constellation even. And then lastly, assessing the resources that are available for the individual or the family. And these are not only sort of personal resources or family level resources, but treatment resources or support resources in their community or in their healthcare system. So those are the main levels of screening and assessment that have been put forward as components that should be somewhat standardized. So how do we define trauma so that we will know it when we see it? This definition is put forward and may be helpful to just give us a framework. So the definition here is when events or circumstances are experienced by an individual as physically or emotionally harmful or life-threatening, and that experience has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So it's fairly broad, but again, it brings in the notion that you identify an event, but also the key thing is the experience that the individual has in response to the event. And so the assessment framework depends in part on the age of the patient or client, as well as the timing or the chronicity of the traumatic event or events. For children experiencing adversity or trauma, interference with normal, healthy developmental trajectories may be the key focus of the assessment. On the other hand, for adults who may have experienced a recent trauma, or again, may have experienced a long-term adversity or stress that may have had more cumulative negative effects, the assessment may look very different. And again, in many cases, there's an identified patient, but in the field, there's a real push toward looking at the household or the family system that may be a more appropriate target for intervention. Because even if an individual has experienced a traumatic event alone, the impacts can be wide-ranging and can affect friends and family, particularly in the household, and so the intervention should take into account not only the support that can be offered through the family system, but also the more secondary trauma that the family may experience, even if they weren't directly involved. So getting into it a little more deeply in terms of the components of assessment, obviously the assessment needs to be comprehensive and cover a variety of domains, but I'm just going to talk briefly about the 4 most common domains that are discussed. The first is how the adversity or the trauma has impacted the patient emotionally. So for example, are symptoms of anxiety and depression associated with the experience or the trauma? Does the patient have normal emotion regulation ability, or even normal emotion recognition abilities, or have those been disrupted in response to this traumatic event or experience? Other things that can be evaluated are, is the patient easily angered or easily startled? Particularly in children, startle reflex and hypervigilance can be observed following a traumatic event. Is the individual more irritable than normal, or are they under or overreactive to challenges? So that's just a small sample of the emotional impacts that may be observed in patients in this situation. A second area is in terms of social skills. So does the patient have difficulty interpersonally, and has the trauma perhaps interfered with either the healthy development of social skills, or has it impacted existing social skills in a negative way? And this is also wide-ranging in terms of experiences with friends, or interest in spending time with friends or romantic partners. It can even impact relationships with coworkers or lost interest in social activities. And another aspect that is often assessed is, does the patient have difficulty understanding social cues? If those were developed normally, those may be interrupted as a result of the traumatic event. A third area is cognitive ability or cognitive functioning. In children, this is often evaluated as school performance or school achievement, or even just school engagement. In adults or older folks, often cognitive decline is something that's evaluated in terms of impacts. In children, it's important to note that inattention or inability to complete tasks may be mislabeled as ADHD or attention deficit hyperactivity, when they could be at least in part due to a traumatic history. So knowing the psychological or mental health history of an individual, particularly a child, may be really important to avoid misdiagnosing certain clinical symptoms in children who have experienced trauma. And of course, there are often physical injuries associated with adversity or traumatic event. And these I think in behavioral health may be less an automatic focus of an assessment, but can be very important as they may cause a patient to, in some respects, re-experience the traumatic event. So that's just sort of a subset of a comprehensive assessment, but I think those are the aspects that are most commonly discussed and emphasized in terms of best clinical practices. So once a provider has a detailed picture of the traumatic event and the breadth and depth of the initial impacts of the trauma, the treatment planning can obviously begin. So I'm going to spend a little time discussing what trauma-informed care models look like and where they came from. So trauma-informed care is a treatment model that is considered a best practice in behavioral health care, but it's actually conceptualized less as a therapeutic technique for individual providers and more as an organization or systems level paradigm. And this is really fleshed out through a variety of resources offered through the Substance Abuse and Mental Health Services Administration, or SAMHSA, as well as the National Council for Behavioral Health. Both of these institutions have invested deeply in the trauma-informed care model, and they argue that addressing trauma is now the expectation rather than the exception in all behavioral health care systems. So before describing the details of an organizational level paradigm, I wanted to just give a little history on where the paradigm came from, how it grew out of work in the addictions field. And so one of the most noteworthy contributors to the early development of this model is a woman named Dusty Miller. She was one of the early proponents of the treatment model. And she herself was in recovery and a survivor of a variety of early trauma events in her own life, and began doing both clinical work and research to really gain a better understanding of the links between early trauma or even later adult experienced trauma and the development of addictions, as well as the difficulty in responding to treatment for addictions with this kind of history. And she's written a number of books and offers a whole host of educational and clinical training resources through a website that we can offer to you if you are interested later on. And so she argued for a tight link between stress or trauma and the risk for substance use problems. And she viewed it through a lens of a diminished sense of security and an inability to form relational attachments, which Christine talked about briefly just a few minutes ago. And also she argued in her earlier work that alcohol and drugs, including tobacco, can often become stand-ins for emotional nourishment when those attachments are difficult or diminished. So again, to just give you more of a feel for where the current field of trauma-informed care came from, I'm just going to go briefly through this sort of timeline of major events in the field that led to where we are today. So in 1994, SAMHSA convened a conference focusing on the high rate of women with physical and sexual abuse histories in the public mental health system. And Dare to Vision was a conference which provided a forum for survivors and consumers to discuss their own traumatic histories and to stress the importance of and the value in addressing trauma in treatment settings, and also to highlight the re-victimization that is too often experienced in residential and inpatient settings through practices such as seclusion and restraint. So that's one of the main events that sort of moved this field forward in the beginning. And then a few years later, in 1998, SAMHSA launched a 5-year study to explore the interrelation among violence, trauma, and co-occurring mental health and substance use disorders among women in particular. So the Women, Co-Occurring Disorders and Violence Study, which was this 5-year study, provided recommendations for trauma-integrated services and counseling for these women. And it also sparked the development of a variety of guiding principles for positive change at the organizational level, including the principle that providers should be mindful of the ways in which their own practices and their own clinical policies might put women in danger, either physically or emotionally, or bring about re-traumatization. So these issues were, again, revisited and then sort of anchored with some hard data collected through this 5-year study. Then in 2004, SAMHSA's division of mental health services built on the growing momentum for trauma-informed care by hosting Dare to Act, which was a second national conference devoted to understanding and addressing the needs of trauma survivors. At this conference, practitioners and researchers and policymakers discussed the 5-year study and also a variety of other related research findings regarding trauma-specific services. And they discussed strategies for implementing trauma-informed care more broadly, as well as sharing personal stories of survival, healing, recovery, and triumph from their own trauma and adverse experiences. Shortly thereafter, in 2005, and as a direct result of these initiatives, actually, SAMHSA funded the creation of the National Center for Trauma-Informed Care. Their aim was to further advance the knowledge base related to implementing trauma-informed approaches for individuals seeking mental health and substance use services. The National Center for Trauma-Informed Care, or NCTIC, has facilitated the adoption of trauma-informed environments in the delivery of a broad range of services, including mental health, substance use, housing, vocational services, employment support, domestic violence, and victim assistance and peer support. So in all these environments, the center seeks to change the paradigm from one that asks, "What's wrong with you?" to a more holistic view that asks, "What has happened to you?" Following those initiatives, SAMHSA hosted a third national conference, which they called Dare to Transform. And at this conference, people working to then implement trauma-informed care shared best practices and began to really form a more concrete model that could be shared and disseminated across healthcare services. And they really explored a number of innovative strategies for organizational change. So rather than viewing it as a model that can be used for training individual providers, they really took the perspective that this was a strategy that had to go top down, from gaining buy-in from the highest levels of organizations and moving down through an organization to providers. So through all these efforts, there was beginning to be a consensus on some of the key elements of an organization that is truly using a trauma-informed care paradigm. And some of these we've already talked about, but I'll just go through them quickly so that you can get a sense of sort of the breadth of the organizational focus that they were taking. We talked early on about the early screening and assessment component, and that obviously is a key element in any context for using this model. The second is consumer-driven care and services. And what they mean in this regard is really tailoring services to individuals' history and perhaps comorbidities. So it's not a one-size-fits-all approach, but services really have to be involve collaboration and an understanding of many levels of need for an individual client or patient. The third element is the trauma-informed and responsive workforce. And so both SAMHSA and the National Council for Behavioral Health have an enormous set of resources for building a very skilled workforce in clinical settings. And I'll talk in a few minutes about some of the specific training and technical assistance that's available so that an organization can really have a workforce that's prepared for working with these types of clients. The fourth element was to be certain that the clinical practices are evidence-based or emerging best practices. And so those are becoming a little more fleshed out and established as standardized practices in the field. The next element is safe environments, and which I touched on briefly a few minutes ago in terms of there's a lot of emphasis in this situation with inpatient care and avoiding re-traumatization with clinical practices such as seclusion and even medication, which may interfere in terms of clinical care in individuals with trauma histories. The next element is community outreach and partnership building. And there's a lot of emphasis in this area on children who've experienced trauma or early adversity in terms of building a lot of wraparound services ranging from perhaps social work or clinical care that's available through their school system, community churches, community organizations that can also provide some scaffolding or support around a child with a trauma history is also important. And so this is sort of a multi-pronged approach where the clinician is only one piece of really a network of providers that can work together to help children and their families work through recovery. And then the last element on the organizational level is ongoing performance improvement and evaluation. And so I think there's a real emphasis on documenting and reporting back to agencies about how the clinical practice is really being implemented, how things are being documented, whether change is really measurable in an organization, and how ongoing training and skill building in the workforce continues. So a few years ago, the National Council devoted an entire issue of their magazine to this topic of trauma-informed care. And in collaboration with the National Center for Trauma-Informed Care, they're offering a variety of in-person and webinar-based trainings, as well as virtual learning communities and care networks that are open to providers of many stripes. Many are offered at low cost or no cost to agencies working toward building this paradigm in their organization. And so, as I mentioned, there's a wealth of resources through SAMHSA and the National Council and a variety of other national centers, including the National Center for Children with Traumatic, I have to get the acronym right, but it's a component of SAMHSA as well, but it's focused on trauma in children. So the training and technical assistance is very broad and very detailed. They have resources, for example, for policymakers, so starting at the top, so to speak, in terms of how to advocate for policies that support a trauma-informed care approach. They have training and resources for clinical administrators or leadership to help build consensus, to help access funding resources to implement the model in their organization, and resources for the leadership in an agency to help build buy-in among their clinical providers and their partners. There's obviously a variety of training and assistance for the clinical providers themselves in terms of specific techniques and resources they can offer their patients, including referrals. And even training for peer navigators, so folks who have perhaps experienced trauma or adversity in their own lives who want to work in sort of a paraprofessional role, supportive role to help patients or clients navigate the healthcare system and connect with community resources or providers that have truly embraced this model of trauma-informed care. The training in TA is also designed for a wide variety of settings. So it's not simply limited to behavioral health agencies that offer mental health and or substance abuse services, but they also have specific training tools for the folks working in the criminal justice system, with folks who have a trauma history and are struggling with addictions or addiction recovery. They also have materials and resources for educators who want to not perhaps use the techniques in the education process, but just be aware of the experiences that perhaps children in their classrooms are dealing with, and offering the support that's appropriate in the educational setting. And there's also a variety of training resources for folks working in the child welfare system so that they can better understand how to approach treatment and support of kids who may be in the foster care system due to traumatic events within their families. More recently, there's been a development of a number of specialized programs that are also available. Many have their own sort of centers being developed with specialized clinical techniques or resources or referrals available. And these, some of these we've already talked about briefly, but they expand across all kinds of contexts, including folks that have active military history or who are veterans who've experienced trauma, folks that are currently homeless or experiencing housing instability and special services that may meet their needs in particular. Other programs for the LGBTQ communities that really address some of the very specific discrimination or trauma events that may be experienced in that population and how to address their needs more appropriately. And even ranging as far as victims of natural disasters or those kinds of rapid changes in living environments or dealing with other consequences of natural disasters and how to address trauma for those folks. So it's really stretching across a number of contexts, and I think folks within those specific niches are really embracing the model and working toward a standardized but also specialized set of services for folks with specific trauma histories and needs. So again, the National Council have developed, as I mentioned, lots of resources. This is just one example of a very useful infographic that they encourage providers to use in their own clinical service, as well as to distribute widely for just sort of as an educational tool to sort of get the word out for folks that these resources are available. This infographic in particular is an example that highlights some of the common symptoms of trauma. There on the left, there's sort of a checklist. And on the right, a number of coping strategies that can be useful. So providers are encouraged to use this as sort of a reminder of the signs and symptoms of trauma in their patients, specifically for providers that may not be working with these clients on a regular basis, and it may not just be in their automatic sort of clinical workflow to examine these kinds of signs and symptoms. So it's sort of a helpful reminder for them. It's also very helpful for patients who can use this to recognize some of the symptoms that they may be experiencing, and also ways there at the bottom, some information about how to speak to your doctor, or how to seek referrals if you're seeking this kind of trauma-informed care, or perhaps maybe it hasn't occurred to an individual that this is something that really can be impacting both their mental wellness as well as their risk for addictions and other problems. This second example describes what they're calling a recovery bill of rights for trauma survivors. Again, this can be useful for both providers as well as their clients for building coping skills and strategies, for understanding boundaries that they may be struggling with, and also it features some information on empowerment for folks that are recovering from a traumatic event. So these are just two examples of the many, many resources available through SAMHSA and or the National Council for Behavioral Health. So just to wrap up, some final thoughts on what we've discussed this afternoon, or yeah, I guess it is afternoon there in Vermont. We've discussed how trauma is shrouded in secrecy and denial, and it's often ignored, and that the field is really moving toward removing the secrecy, addressing the stigma and shame associated with trauma, and really bringing it out as a very, very important element to be addressed clinically for folks with a whole variety of potential adversities early on or recent trauma events as well. When we don't ask about trauma in behavioral health care, harm is done or abuse is unintentionally recreated. And so the model is really aimed at a really systemic change in the field to remedy that situation. And so addressing trauma in your organization can help both your organization and your clients. It can improve the quality and impact of behavioral health services. It can increase safety, not just for the clients, but for your providers as well. It can enhance client engagement and reduce no-shows. They've actually now began studying these workflow kinds of issues in terms of client engagement and whether folks come back for follow-up appointments and so forth. And it really is showing an improvement in that kind of engagement. And this model has also been shown to reduce staff burnout and turnover. So while you're helping clients, and that's typically your first priority, it also can have a very positive feedback loop for providers who are at risk for a very stressful, I guess, trauma fatigue when working with these clients on a regular basis. So I'll end by just, again, showing you our information so that you can reach us if you are interested in receiving more resources. We can provide follow-up information or a variety of links to some of the resources that were discussed, or even the research sources that we use to put this presentation together. So don't hesitate to reach out if you would like some more information on this topic. And we'll stop there, and if we have a few minutes, we can address comments or questions from anybody attending. And thanks again for participating today.
And just as a reminder, we have actually moved over to a newer platform for our webinars, such that you should see a button that says raise hand. If you would like to ask a question, please feel free to press that button in order for us to be able to see your question. Otherwise, as Susan said, we would be able to answer any questions after the webinar, any follow-up questions. Okay, we're showing, Sandra, are you there? Your microphone may work. If not, you can use the chat function. I saw that your hand was raised and we've added you to be able to speak. Sandra, can you hear me? Okay, well, if you have a specific question, you can ask it through the chat functionality by through double-clicking on either my name or Christine's name on the panelists. Okay. Well, doesn't seem like we have any other questions being asked or hands being raised. Again, feel free to follow up with us at bh.wellness@ucdenver.edu. You can also reach us through our website at www.bhwellness.org. Again, thank you to our presenters today, Christine Garver-Apgar and Susan Young, and have a great day for the rest of your day, guys. Thanks.